to look at some medication issues. Now, we know that the older generation medication has been stopped because of their severe side effects. Now, please understand that aggression and pharmacological intervention should be used only and only if aggression is uncontrollable, continuous, chronic, and has caused serious issues. So to reduce aggression among youth in a variety of complex and comorbid disorders, whether you use atypical antipsychotics like risperidone, now the side effects are much less. There may be some weight gain and all that, but other atypicals have scattered reports. But in start low and go slow, this kind of helps. In those children who have ADHD, severe ADHD and aggression in the context of ADHD, the significant behavioral effects of treatment of ADHD-related aggression, and that these effects are independent from but similar in magnitude to their effects on the core symptoms of ADHD. So stimulants, particularly methylphenidate and atomoxetine, can be used. There are a group of children who have significant mood regulation problems, even mood disorders and aggression. ADHD is comorbid with mood disorders to the extent of 30%. And that's where either lithium or valproate would be very important to consider. In those kids who have significant aggressive behaviors in the context of OCD, or those children with autism spectrum who have significant aggression in the context of ritualistic behaviors, and if you stop them, they hit and bite and all that. Perhaps a judicious trial of SSRIs and fluoxetine. And those who have impulse control problems in the context of ADHD, perhaps a trial of clonidine or beta blockers, especially where there is explosive stuff that takes place. So this is the kind of stuff that one
palatable, understandable by common pediatricians, because
that's the kind of duration that one needs to keep in mind. That Subodh reminds me that there is a question of his that is pending, and I'm trying to find what the question is. Can we make this behavioral training more practical and more clinical? If Subodh, that's the question, and that's the point that I made just now, that I'm happy to do a hands-on session, which is a practice session, which will not be. So we actually do case studies, and we do practice sessions. That I'm happy to do that as an add-on to. Mandira Roy's question: is there a book for learning to for behavior modification for pediatricians? Mandira, I would actually recommend the material that we have put out, because they're very simple and they're doable on the field. So if you look at nimhanschildprotect.in, you will find that a lot of material which is practical for you. Dr. Swati Ghati's question: can medications be used as first-line management by pediatricians, as we may not be trained as therapists? I would be circumspect, Swati. I would be circumspect, because there is a tendency, not just in pediatricians, but among psychiatrists as well. And here is the tendency: whether it is anxiety or whether it is aggression, there is a tendency to say, "Bachcha hai, घबराएगा तो ही या चंचल तो ही, हरकत तो करेगा," and you do not treat and allow the child to suffer because you believe that it is developmentally okay when good treatment is available. On the other hand, there is anxiety, there is aggression, but it is clearly environmental in origin, clearly can be handled. But then these kids come with horrific prescriptions of 6 to 7 tablets. So I think some balance and circumspection is required here. And I feel everywhere some basic trial of parent management techniques, of home routine, of some kind of charting, some behavioral prescriptions, some agreement with the child to give it about 6 to 8 weeks before you really choose medication is the one that. So the storytelling part, Mandira, is there entirely in the. We've put out a lot of stories in the material that is there on our website. So do have a look at it. How does the parent handle the child when the behavior changes in good and bad days? See, there has to be a balance here that in terms, there will be good days and there is bad days. But if you remember your mathematical formula, if you look at the ebbs and the flows, and if you do a point, a graph where you look at the ups and the downs, you chart it on the various points, and if you find that actually the graph is towards improvement, then it doesn't matter where the peaks and the troughs are. So there's no need to have a knee-jerk response to days where there are highs and lows, as long as you're very clear that you appreciate the kind of stuff that takes place when a child shows behaviors that. There are many other questions that have come up. We've, of course, recognized about the level 2 program, and I'm happy to discuss this with, and I think Nandini would be delighted as a follow-up, and we'll plan this and do it in a planned way to have 3 or 4 sessions where we do a level 2 program. I'll quickly respond to Subodh. I have posted the NIMHANS website. If you scroll up, you'll find it a little higher. And it's NIMHANS. Of some kind of charting, some behavioral balance and circumspection is. And so that's the kind of duration that one needs to cruelty to animals and to discuss with it, and we can conceptualize a level 2 program. It may not be 15-20 sessions. We could do a 3-session or a 4-session program that looks at a practical training. So we actually do field training part of it, and we can do it on online mode as well. Coming to the second point about red flags, I think Jason has raised a very important issue. One of the most stable markers of later adolescent problems is the presence of externally directed aggression in very young children, who are throwing stuff on. So oppositional defiant disorder in very young children who are very cranky, very demanding, is a definite red flag for those children who are going to possibly move into conduct symptoms. That children who do not show emotional responsivity to the pain and suffering of the others, or you find that they draw some kind of pleasure at hurting. So, this whole cruelty to animals, and these are signs that, and that's where the development of empathy-related issues become very important to the kind of point that Jason has raised. Now, coming to a question that Lata Bhatt has raised on how many sessions on an average are required in CBT for difficult behaviors. It depends on the duration, the context. Is there a lot of family pathology and these kind of issues? But by and large, if you look at the Brain Power program that I spoke about, a minimum of 10 to 12 sessions are required. But in difficult cases, sometimes our sessions last several months on end. So that's the kind of duration that one needs to keep in mind. Subodh reminds me that there is a question of his that is pending. Sexual behavior, and the other on an elaboration of memory bias and how it gives rise to aggression in children and adolescents. I perhaps may not have the time to delve into it with detail, but suffice to say that when there is overt sexual behaviors, parents, pediatricians, parents, do not freak out. Do not, when young child play with the, chi chi chi, mat karo gandi baat hai. As opposed to using distraction, as opposed to using the approach of hygiene, because we don't want them to get an idea and grow with the idea that handling genitalia is bad or wrong. Because sexuality is a beautiful experience in the right context, and so we must allow them. So if you look at our website, we've spoken about health and safety, privacy and boundaries, consent, communication. So that's the way that one handles overt behaviors. Madhu, as far as memory bias is concerned, it's a question, see, memory bias and attribution bias go together. हमारे साथ कुछ होता है, हमारी कुछ धारणाएं हैं उस पे. So next time it happens, our memory goes back, tab aisa hua tha, ab bhi aisa. Though all episodes are not the same, all people do not have the same intent, though it appears to be the same. So what we do in discussion with when we work with these kind of adults who say, yeah, I acted angrily because पिछली बार भी ऐसा हुआ था और उसने ऐसा कहा तो मुझे मार. But to say, इस बार can we discuss whether it's the same person or the same intent, and could there be other intent? And that's the way when we look at alternative possibilities and alternative explanations, alternative ways of responding, that it would become very important to deal with. With that, I hand you over to Dr. Nandini.